Welcome to ADAPT NCLEX. Thank you for joining us. This is our Wednesday review. Today we're going to talk about maternity. This is something you have to have it down before you take the NCLEX. I'm just going to focus on the prenatal teaching. The NCLEX is all teaching as a nurse, teaching and education of patients because they need to know what to do, especially when it comes to maternity. It's all teaching and teaching. So don't memorize the information. So we're going to use a case and then we work it through. So you have a 25-year-old female in the OB clinic. The question is, she want to get pregnant. I want to get pregnant. So this is a common question. They won't tell you like that. They may not ask you, but this is the frame of the question, right? The patient want to get pregnant. So as a nurse at the OB clinic, what are you going to tell this patient? So what kind of questions you want to do? What kind of physical exams you want to do? So at this prenatal visit, she's not pregnant, she want to get pregnant. So there's certain things you have to do before she get pregnant. You have to educate her, you got to teach her certain things. So what are the things you think you should be doing on your physical exams in the beginning when she come in? Of course, you got to do a comprehensive exams, right? So I will start. If you can type your answers. So comprehensive exams, do a physical exams, do GYN exams, ask history, ask previous pregnancy, all of them, right? So these are the things you want to know. You have to know the RH factor for this patient, right? What else do you want to do? What else? Any other thing you want to do about this patient blood type is very important. You got to check your HIV. That's what somebody say. I got to know about the HIV status. I got to know about HIV status. You got to know about previous STIs, whether she's had, in addition with the HIV, other ones, right? Chlamydia, gonorrhea, so all of them. CG, chlamydia, syphilis, maybe HPV, HPV, syphilis, all of them you have to pay attention to that. You have to ask the patient about them, well, tighter. And then there's certain things they can ask you about rubella. You have to be careful. If she's not pregnant, then we can give her you check the titer and the titer is low, you should vaccinate this patient. Then, so that's very, very key. She's not pregnant and she came in and you check her titer and the titer is very low, you should vaccinate her, right? But then when you vaccinate her, you tell her to wait for at least 4 weeks before you get pregnant. If she's already pregnant, then nothing to do. Nothing to do. Nothing to do if a titer is low. You just have to wait after delivery. Then you immunize this patient. So that is the key. If you see a question like that, so that's it. You also want to know what kind of medication she's taking. Excellent. So I need to know what kind of medication you're taking, right? How many pregnancy you had, right? Previous pregnancy. So you want to know GP history. This is very important. So you can know previous pregnancy, any abortion, any living children, all of them. You got to take, this is how you take the GYN history. So this is a little bit comprehensive, right? Review of system. Um, I would like to know about a CBC because anemia is very common during pregnancy. So I got to check a CBC, make sure it's okay. Right. What else do you want to check? Um, it's very important. Check your urine, right? Check your urine for glucose, check your urine for protein and make sure she doesn't have any diabetes, undiagnosed diabetes. Um, then you want to know if she taking oral contraception, right? So all these is a very comprehensive history. So if you see a question, these are the things you may probably see in the question they may ask you. Yeah, the H&H is the same as the CVC. Then, oh, you check all these things, then you got to do some education, right? Education. Everything came out perfect, right? So how are you going to educate it? Number one thing you tell this lady, this guy, folate, they need at least 400 to 800 micrograms per day. So it's very, very, very important. This is very important. Well, she may not know what is folic, right? How can I know folic? Do I go and eat hamburger all day to get folic? So expect the NCLEX to give you a list of information and ask you which one is good for folate, which one the lady should take, right? Um, the most important one is vegetables. It's very fresh leafy vegetables. Um, a very good source of uh, um, folate, right? Freshy, leafy vegetables, basically. Or you can have fortified grain. Fortified grains are very good source. Even Spanish, it's also very good. Broccoli. What else? What do you think? Well, I think as high source of folate that you got to teach this patient so that they can increase in it. People don't know, but peanut butter is so good. Peanut butter, yes, about 800 microgram. It's very, very, he has a high level of folate. So that's another source that the mommy can eat. Of course, pasta and rice are also, but they're not great. But peanut butter and fresh leafy vegetables, even fish, some fish are very good source of it. So yeah, that's number one. Why are we doing this? Why do you want a teacher to increase your folate intake? It's because it's very dangerous. They can lead to deformed baby. But what is specifically is the problem? Is neurotube defect. This neurotube defect, if there's a lack of folate, this is the problem that will lead to that. It's a lack of folate. So that's why you want to tell the mommy to increase the folate to prevent that. It's also help with the brain development. But the most important thing is a neurotube defect. It prevents neurotube defect. Teratogens are bad. So they should stop doing certain things that are very teratogenic. Yeah. One of them is alcohol. So ETOH. Stop it. Don't take anything. Don't minimize it completely. Don't do that. Okay. Smoking, tobacco. This will cause abortion. Okay. Ischemia is not good. So you should avoid it. Right. Recreational drugs, right? You should avoid all of them. Otherwise, your baby is going to get into trouble. And there's some medications you should know, medication to avoid. If they are already taking it, they need to talk to their doctor to change it. Which medication you should avoid in pregnancy? What do you think? I'll tell you ACE inhibitor, it lead to renal agenesis. Basically, your kidney doesn't develop well. So ACE inhibitor, you know them. I don't have to mention them. The pearl, enalapril, lisinopril, right? So they should avoid these medication as much as possible. Um, Lithium is not good. It's teratogenic. If you have bipolar and you're taking lithium, your doctor need to change that medication for you. If you have cholesterol problem, statins, you should change it. Okay. If she has DVT, she should change. If she take warfarin, it's not good. So you can't take warfarin. So we may have to change it to heparin derivative for you. So these are little things. This is why OB is a little bit difficult. It's like these little things, a bunch of, it's like a med surg. You cover everything, right? You got to bring pharmacology, right? What other medications should they avoid? What do you think? Um, is a medication you use it for acne. Anybody knows the name? You use it for acne. They should avoid it as much as possible because it's also teratogenic, especially a young patient like that in college probably have some acne and probably will be using it. They need to know they are vitamin A derivative, right? It's a vitamin A derivative. The medication is isotretinoin. So this is the medication. It's an acne medication, and they should avoid taking it. Sometimes they won't use that. They will say retinoid is also fine. It's the same medication. But this medication, another name for it is called Accutane. But I don't think you want to use the one, you want to know the one your board will likely use it, right? So they will probably use isotretinoid. But there's Accutane or retinoid, but this is the one they will use. So they should avoid it. It's a vitamin A derivative. They should avoid it. NSAID is tricky. You got to know this is the content, right? First and second trimester is okay. But when you get to the third trimester, stop it because it leads to premature closure of the ductus arteriosus. Remember, when the ductus arteriosus is between your lung, your the pulmonary vessels and the aorta, and it shunt blood from the lung as the kid is not developed. So if this is your heart like that, and the pulmonary vessels and the aorta, you have the ductus arteriosus is here, and it shunt blood with the lung sitting here. So blood is bypassing and going to your system. As soon as you get born, the ductus arteriosus is supposed to close when you take your first breath. If it doesn't close, we call it PDA. So PDA is actually a ductus arteriosus, which was doing good job shunting blood from your lungs to the circulatory system. When you take your initial breath, your breath will cause closure of the ductus arteriosus. But if it doesn't, it become what? Patent ductus arteriosus. What causes that the ductus arteriosus to close? It's usually NSAID. Therefore, if you have PDA and you are born with PDA, we give you NSAID. So mommy should avoid taking NSAID during the third trimester to prevent the premature closure of that. That is the explanation of that. If you want to know more about it, I have a free congenital heart disease, and you can check it, and you'll be able to on YouTube. You explain how the mechanism happen. So these are little things you tell them. Then there's another medication, methotrexate. So anything like that, this can cause abortion. So if they take it, they should avoid it. This is the key. Anti-epileptic. So I call them mood stabilizers, but let's use the anti-epileptic. So these are like a phenotime or carbamazepines or valproic acid. This is key, right? Most of these patients, they have like seizure disorder, and then they can't stop this medication. These medications and is cannot stop it, and they're pregnant, right? They can't stop it if they're already pregnant. The problem is If they cannot stop it, we got to talk to the doctor to basically help them deal with the neurotube effect. So they get a high dose folate because they can't stop the medication. But if they can stop it, then you can change it to another medication that doesn't cause problem. But if you cannot change it, you see a question like that, a pregnant lady taking antiepileptic and is pregnant and cannot stop the medication, look for the answer that say high dose folate. You should give it to them because then that will counteract the effect of that because they can't stop the medication. Otherwise, they will have seizures and they are already pregnant. Well, we got to deal with it. Then you got to tell them, wait, we want you to be ideal weight before you get pregnant. So 18.5, you want it to be 18.5 and 24.9. This is very ideal weight, the best weight to get pregnant. Of course, not everybody can be like that, but this is your teaching. You can provide them. There's one more. I want you to know it. It's very, very good. It's very important. You may see it in the question form. It's dentition. They need to go see a dentist because periodontal and disease is very, very bad during pregnancy, right? These get worse. So they got to see the dentist to make sure their teeth is okay and everything. Otherwise, it can go worse during pregnancy. Okay, so those are a little few things I want you to think about before they get pregnant. So this is an anticipatory teaching that you can provide for them. Now, assuming she's pregnant now, and she's in the first trimester, which is usually the first 1 to 2, basically a few weeks, right? Is between up to the first week to the 12th week. So up to the 12 weeks, right? This is the 12 weeks. So that's how long is the first trimester, first, second, third, fourth, up to like 3 trimesters, but each of them is about 12 weeks. So she's between the first week to the 12th week. They're going to tell you so many things. There will be certain things that will be changing in this lady. So they will be complaining. They will be complaining about certain things, and you have to be aware of it. For this lady, if she's pregnant, the first thing you need to do is check the ACG and see what level is it, because it's supposed to double like every 2 days, right? It double, so it's supposed to double. If it doesn't double, then we know the kid is in trouble. But these level of ACG can cause problem, right? It can cause specific problem. What it does is it's mostly responsible for the nausea that they feel, all the changes that happen, and they keep the baby from the couple. We call something we call corpus luteum to persist to help with the pregnancy to proceed. And hormones um, going to change. These hormones is going to change. It's going to cause nausea, vomiting. So you have to check those levels and make sure the mommy is aware about it. It causes breast enlargement. So there's common symptoms she'll be complaining about. Nausea, of course, and vomiting. That's common. What else would she say? What else would she complain about? Tell you her breast is enlarged. What else? She'll be tired, frequent. She'll be fatigued, right? You know what I mean? And a urination, a frequent urination. You're going to see some skin changes in this lady, right? Skin changes as she comes in. What else do you think? There's certain changes that will occur. A cardiovascular system, you have to know some of these things. What is going to happen? The blood volume is going to increase. What one thing when you saw in the cardiovascular system you should worry about? There's one thing you should worry about when you see in the cardiovascular system. A blood volume is going to increase, it's fine, right? But there's one thing when you see, if you see diastolic, mama, you should not see that. If you see that, that's a problem. This is bad. How about the respiratory status? As the uterus get bigger, it pushing the diaphragm, so the total lung capacity is going to decrease, and it will be a little bit tachypnic. The GI, well, this is all common. We're going to have constipation. Don't worry about it. These are all normal findings you should expect. How about endocrine? What do you think? We do a lot of stuff during endocrine pregnancy regarding the endocrine. Because of this, we worry about that. So what do you think? Endocrine, what things you should expect, you should be checking for this lady who is pregnant, endocrine, expected finding that you may see or you should be worried about and follow up on it. They are going to be insulin resistance. This is why we check their blood glucose. So they feel like the pregnancy itself make you become like diabetic, right? You need more insulin to break down your glucose. So they are insulin resistant, basically. So that's why we check their in glucose tolerance test and make sure they're not becoming having gestational diabetes. So this is very important. Like that's why we do that. And then hematology is DVT, common in pregnancy patients. So you have to check their calf. You got to teach them walk. You don't lay on it. All those things. They are hypercoagulable states, so they're more likely to get a DVT. And as we talk about, if they get DVT, you cannot give them warfarin. You got to give them heparin. What else do you want to tell her? She's pregnant. She's in a clinic. You want to tell her what? You should avoid certain things. Things you should avoid. What do you think? Avoid the touch, right? Avoid the touch. These are disease process she should go away from. Toxoplasmosis. This is toxoplasmosis. They should go away from it. The O is like syphilis, so this is other. So this is like syphilis, HPV, parvovirus, varicella. They should get away from it. Rubella, stay away from it. So if somebody have this problem, you should run away from them. Okay. If somebody have CMV, you should run away from it. And somebody have herpes, stay away from them. These are what we call touch and disease process that they should avoid from it. You should tell them to avoid unpasteurized milk. Why? It's because of listeria. It's organism that can cause infection and that. Then you should tell them to avoid like unwashed fruits and vegetables. This is because of toxoplasmosis, right? And then you should tell them to avoid cat litter. Not that they cannot have cat, but they shouldn't pick the cat litter. Why? It's because of toxoplasmosis. So they can have a cat. Don't throw your cat away, but you should stay away from the cat litter. Of course, they should avoid some mercury in food. So certain things they cannot eat is very important. And then you tell them about vaccines. What vaccine can they avoid getting? What do you think? Vaccines they should avoid. What vaccine would you tell this lady? You should never get this vaccine, no matter what. What vaccine would you tell her not to get? Get MMR, right? She should not get varicella. So those are all live vaccine. So what are those? She should not get HPV. These are live vaccine. She should not get oral polio. If you don't know them, these are live vaccine. She should not get what? Flu vaccine. Is that true? She can get a flu vaccine. She should not get the nasal one. The nasal one, you cannot get the nasal flu vaccine. Rotavirus is also they should not get. So these are few vaccine they should stay away from it. You don't have to memorize all vaccine, but if I you, I would just memorize those they should avoid. So if they give you other question answers like TDAP, it's okay, right? TDAP is okay. Like if they give you some of this, so all you need to know those they should avoid. So if they give you a selected apply and it's not those they should apply, you pick it as an answer. So it's a like test taking strategy, So um these are very, very important information that um, you can tell them to avoid. It's very, very important. Um, live vaccine usually make them immunocompromised, and then so because of that, you should tell them to do that. The You may have to calculate a pregnancy, right? A due date, which is very important. So everybody have their own way of doing it, but I just do the first day of their period, that's their menses. You subtract 3 months, whatever you use to calculate it is fine. Plus 7 days, and then plus a year. That will give you the due date. Some people take the first day out of it and they use 7 because you can subtract this. You can use the last day of their menses. But this is the best way to calculate it. If whatever you have work for you, this is the way to calculate it. And then you calculate it. And then you can teach her things that they should do and let her go away. So these are little things your board may ask you that you should be comfortable discussing. Remember, she's going to vomit and she'll have nausea. They will call it morning sickness. But it can get worse. It can get to the second trimester and still doing the same thing. And this is what we call hyperemesis gravidarum. If your board give you this, forget about OB. They're not going to ask you OB anymore. This has become fundamental. This is fluid management. So change your brain and answer every question in terms of fluid management. So what do you expect? If somebody have hyperemesis gravidarum, the best way I want you to think about it is you have a patient with the NG tube in place. So they have NG tube because they're going to be vomiting. What are the lab work you should expect in a patient with NG tube? That's all, right? It's going to be hyponatremia, so low sodium, right? And then you're going to have low chloride because you've been puking all the salt and the acid you're puking out is everything will go down. So your acid goes down. When your acid goes down, your base up. So their bicarb is up, right? In the process, if you check, I did a video on furosemide, how the kidney work. As you lose too much sodium, you start exchanging with potassium. So they're going to have low potassium in order to get your sodium back. This is the lab work. So this is what we call um, hyponatremia, make hypochloremic, hypokalemic, metabolic alkalosis. This is like somebody who as NG tube is the same things. This electrolyte is the same electrolyte imbalance you should be comfortable with. But yeah, they're going to have dry mucous memory. Their BUN is going to go up because they're dry, right? Their creatinine is going to go up. All these are lab work you should do. Their urine specific gravity is going to be what? High, because they're trying to absorb all fluid from it. So these, when you see this, they give you a patient who has this problem. That's what they're trying to teach you, like dehydration. This patient will be dehydrated. And then your treatment is hydration and some other adjunct, right? Crackers. You give them some crackers or ginger, um, right? Small frequent meal. These are the things you tell the mommy to do. I'm just giving you very quick information, short. You don't have to make the studying difficult. Straightforward information so that when they ask you question, even if you wake up in the morning, you'll be able to figure out, that those are the contents to that you have mastered it to the point, you know it, you can answer it. So these are little things you should expect your board may ask you. Well, there can be complication in a first trimester. Complication is bleeding. Bleeding is number one. So what are the things that can happen during the first trimester? Before that, if you see a question, how much weight should a mommy gain in first trimester? You should know this because it's one of those questions you see, which of these you should intervene? Or they will call you and say, I've gained so and so. Should you intervene? How much weight should the mommy gain first trimester? If you know, you can put your answer there. What weight, how much total weight should they gain? What do you think? So you should gain 1.1 to 4.4 pounds. So you can get 2 pounds. So you can get 1.1, at minimum 1.1, at maximum 4.4. No matter your weight, this is how much you're going to gain. 1.1 to 4.4. No matter your weight, first trimester, this is how much you can gain. But it changes as you progress to second, third trimester. And that will be based on your weight. First trimester bleeding. There's few things that causes first trimester bleeding. And that is what? Miscarriage, right? Ectopic pregnancy and molar pregnancy. This is a whole lecture, right? This is a whole lecture, but these are first trimester bleeding. And the strategy is if they give you a question and they say the mommy is what, 10 weeks, it's first trimester and it's bleeding, you cannot tell me it's placenta previa. You can't tell me placenta abruption, right? The board will not do that. They won't confuse you. They will always ask you something that is general. Most first trimester bleeding fall under that: miscarriage, ectopic pregnancy, molar pregnancy. Um, Maybe so you can limit your options. So it's a content base, right? When I see 12 weeks old lady and bleeding, I know this is the three things that can happen. Either they have miscarriage or not. And a miscarriage, it can be spontaneous, mostly spontaneous. In this occur about between 10 to 15%. So it's very common, right? Um, and the most common weeks is about the 8 weeks. Yeah, they're going to bleed, they're going to have cramping, they'll pass clot. The most important to make sure we get the ACG and make sure you go down completely. So serial ACG as much as possible. So if you see a question like that, they need beta ACG to make sure you go down. And just the comfort. And don't forget to tell her to go back on folate and multivitamin right away. Right? Of course, they should, pelvic rest is very important. If they give you a topic pregnancy, it's going to be classic. What do you guys think? What, in the case from a topic pregnancy, what are you looking for? You should know what you're looking for so that when you're reading the case, you know that, oh, this is what is a topic pregnancy. And I call them buzzwords. There's few buzzwords when I know that this is a topic pregnancy. And so what do you think? What do you think? You see in the case form, you say, oh, this is a topic pregnancy. I've given you one, right? First trimester bleeding. That's one. It's going to be unilateral. It can only be both sides. Unilateral groin pain or pelvic, right? Pelvic pain. Of course, they're going to be bleeding, right? What else will happen? They may show signs of shock, right? They may have dizziness, you know, they may show signs of shock. They may be hypotensive. Um, the pain can also go to their shoulder. It does not matter. It can go to right or left, depending on which side they have pain. So either the left side, you go to the left shoulder, either the right side, you go to the right shoulder. But these are four things you should know. First trimester bleeding is one groin and it's going to the shoulder, and they may have signs of shock. So that's the key. They may trap you with ectopic pregnancy. So watch for it. Topic pregnancy, there's two things you should know, two things. Do you have symptoms or no symptoms? And that is the confusion. If you don't have symptoms, most of the time you go to the hospital, they did an ultrasound and they found, oh, you have a topic pregnancy. The baby is in the fallopian tube, but you have no symptoms. You are not aware of it. You start having symptoms when it's about to rupture or you bleed. So if there's no symptoms, don't choose in the select or apply or intervention. If they give you a case ectopic pregnancy, pay attention. Don't just choose this medication, methotrexate. Don't pick it. Okay. You use it when you have no symptoms at all. And this will go and cause spontaneous abortion and kill the fetus that is outside the uterus. And that is fine. This is your treatment of choice. So medication. But if you have symptoms, you go to surgery. But before, we need to resuscitate you. So we get you, we give you some blood, we check your labs, we make sure you're okay. Mommy is stable for surgery. So this is the two things that don't forget. If you give you a case and they put methotrexate there, if mommy is having pain, he's not getting methotrexate. So pain is the first thing that will distinguish between them. Okay. And the last one, before I go, the molar pregnancy. This is adaptive. Basically, this is not a true pregnancy. Two things. This is the ovary and this is the sperm. They all came together. They form a baby. Unfortunately, the placenta overgrow the baby. So this is all placenta. and the baby dies. So what you see is a big uterus, big uterus. It look like they have twins, but there's no twins, but there's no baby. It's all full of what? Placenta tissue. And so molar pregnancy is not a true pregnancy. You have to tell the mommy that, oh, you're not pregnant. This is it's a tumor basically. We got to remove it. It's called adaptive. On the ultrasound, you see a snowball features. Those are the bars where you see, and then the mommy will need a DNC. So this is a brief maternity. You see first trimester, prenatal, and then first trimester concept you have to know. Separate OB like that. Next time we do second trimester, what are the things I need to tell them? Third trimester, then we deliver and the labor. You see, like it's a small content that you got to master. Any question before I go? You guys have a good day. This is ADAPT NCLEX. If you're new, you can see down, you see ADAPT NCLEX. You can select and join our membership or just subscribe for free videos. You can share the videos with your friends, or you can join our class course that is coming up on the 2nd January. You can check my website. But good luck. If you have a question, you can email me. But hope you learned something from Obi. Take care of yourself and then good.